My report will be devoted to indications and counterindications for intravascular thrombectomy and case of internal carotid artery occlusions.
Alexander already mentioned the evidentiary base that today we have sufficiently significant trials proving that with occlusive lesions of ICA, stenting is indicative. Here are the results of the paper 2018 when comparison of several revascularization techniques was done, stenting, balloon angioplasty, and it was proven that disaggregant stenting gives the best performance in terms of revascularizations and functional outcome. Titan gave the same outcome that patients after stenting had the best functional outcome. 2020, another paper, meta-analysis, which again confirmed that successful reperfusion was to the benefit of patients who had stenting comparable to balloon angioplasty. Mortality rate was the same, and favorable functional outcome again was better in case of stenting. In my opinion, with extracranial region of ICA, the issue is a big risk of massive distal embolia in ICA in case of revascularization. My vision is that we should put maximum efforts in the occlusions of the intracranial region to prevent migration of distal clots, because these clots are quite big. My preferable technique is 2 balloons when we perform occlusion with both occlusion balloon catheter and the catheter that is used for balloon angioplasty. How do we do it? Let me show you a clinical case. Patient 76 was admitted 5 hours after the set of the disease. On CT, we do not see any lesion. MRI shows us the lesion, occlusion of ICA. And here, I prefer panangiography in order to evaluate the degree of closeness of Willis's circle, probable distal embolia, which already could emerge, and to evaluate how the clot is developing. Here we can see that anterior regions of Willis's circle are closed. There is a collateral blood flow through the anterior communicating artery. You can see that there is an embolia in one of the branches of MCA, occlusion of intracranial region of ICA, and at the occlusion level, we see that the cavernous segment is filled in due to anastomosis of the carotid artery. 2 balloon techniques was used. The occlusion guide catheter is installed. The 14-French guide was put. The balloon angioplasty of the ICA ostia was performed, and then the balloon was deflated and put upper. Then it was inflated more distally, deflated on the occlusion catheter, and against continuous aspirations on the guide catheter, the aspiration catheter is moved further to the distally installed balloon, which constantly closes the blood flow on ICA, minimizing the risk of distal embolia. And when the guide catheter was put as high as possible, we inflate it, block the cerebral blood flow, deflate the balloon which we used for balloon angioplasty, and then the standard approach against the occlusing guide catheter, we put the microcatheter behind the occlusion zone. Here, occlusion is one of the branches of MCA, and here we need to understand which branch we should get in. We performed super-selective angiography. The microcatheter is performed behind the occlusion zone, standard river install, standard thrombectomy with blood flow restoration, and then the guide catheter is not put into the common carotid artery. The angiography of the ICA artery is performed in order to evaluate the further tactics, how to treat this patient. Here, pretty smooth ostia of ICA, so we were thinking for quite a while whether there are indications for stenting. There were no obvious indications, so we decided to wait a little bit, and then we noticed that the ICA began to close because this plaque was not stable, so we performed the stenting CT in 12 hours in the ischemic area that we saw on MRI. It was formed in spite of successful restoration of cerebral blood flow, but there were no signs of hemorrhagic transformations. Going back to disaggregant therapy, in our clinic, we've been using glycoprotein receptor blockers since 2018. Here is the protocol. 10 to 15 minutes before stent implanting, we introduce the bolus dose of glycoprotein receptor blockers, and then we'll introduce intravenous half of the recommended dose for the patient, then stenting. Then the patient is sent to the pit ward of a neurological department where 300 milligrams of aspirins are administered. And then the glycoprotein receptors blocks are withdrawal, and if there is no elements of hemorrhages, we abolish it. If a hematome is shown, then double therapy is abolished. Otherwise, if there is second type, then only aspirin remains. So again, for 4 hours, we use blockers of glycoprotein receptors, hoping that aspirin will start working, and then the blocks is withdrawal. Maybe we'll reconsider it and use this therapy for a longer period. Anyway, 29 patients were operated, or 23% of the patients with mechanical thrombectomy. In most cases, we used eptifibatide. Since last year, we've been using tirafiban. Few more cases. Here is a patient, 68 years old, delivered to the clinic very quickly. No ischemia on visualization, but you see here, DVI show the signs of developing ischemia. ICA occlusion, panangiography, Volodyukhin circle is not closed, occlusions of the intracranial regions of ICA two-balloon technique, revascularization. The blood flow intracranially is restored, and after restorations, we perform the carotid angiography. We see a plaque that we cannot leave. Stenting is necessary. We did it. 12 hours later, CT. Another male patient, he was preparing to go fishing early in the morning, and then the incident happened. Here are the screenshots from our chat, and neurologists sent us a message at 6 o'clock that this is the patients, let's do it. We do not have any signs of ischemia on CT. MRI shows occlusions of ICA and one segment of MCA. Here, the occlusion of ICA was subocclusion with the sign of floating clot on ICA. Here we used occlusive guide wire catheter. We didn't have it at the moment, so we decided to go for a technique described earlier. We used the Eric retriever as the filter to protect from distal embolia. At the same time, if clots are collected, we wanted to be able to remove it. Upon a stent implanted, an aspirational catheter was put to the M1 segment of MCA. Thromb extraction was performed with cerebral blood flow restoration CT in 12 hours. No signs of hemorrhaging, double disaggregant therapy. This is a more complicated patients, a massive clot, MCA occlusions. We do not see any serious ischemic changes on MRI. Tube balloon technique, stenting of ICA in the common carotid artery, and in spite of the occlusive catheter, embolia still developed in ICA. The patient either had a spontaneous recanalizations or recanalizations happened due to blocking of hypoprotein receptors, or we were just lucky. But nevertheless, in the anterior region, ischemia wasn't developed. And other patients, serious neurological deficit, occlusions of my segment of MCA, according to MRI, angiography showed that apart from occlusion, the patients also had the subocclusions of the ostia of common carotid area and the distal part of common carotid area. Stent retriever was used, and then we were supposed to decide what to do, to stent or not to stent those two elements. In view of subocclusion, we decided to go for stenting. 12 hours later, CT showed no sign of hemorrhage. So using the blocks of hypoprotein receptors enabled us to restore the cerebral blood flow in 75% of cases. Stent thrombosis was observed in 14% of patients in the first 2 days. In view of the symptomatic hemorrhagic transformation rate, very low, we perhaps will reconsider the protocol and increase the use of glycoprotein receptors. Mortality pretty high, 24%. Favorable functional outcome, only 20% of patients. Lower than the literature data, where the results are fantastic. That's what foreign authors report to us. 80% favorable functional outcome for ICA occlusion. We can slightly doubt those data. Anyway, stenting and receptor blocking prevent development of carotid stent thrombosis when implanting is necessary, and it also doesn't increase the rate of hemorrhagical transformations.